When you scroll through social media or look up these intimate wellness clinics, you're usually greeted with this incredibly pristine imagery, like soft lighting, marble countertops, maybe a minimalist font promising, I don't know, rejuvenation and natural vitality.
Oh, absolutely. It all feels very spa-like, very clean and highly controlled.
Right, but the moment you step out of the marketing brochure and into the actual treatment room for regenerative medicine, well, that pristine image kind of collides with the messy, complex reality of human biology.
It is a really stark contrast because, we are fundamentally talking about procedures that require needles, extracting bodily fluids, spitting them down in machines, and injecting them back into highly sensitive tissue. You are essentially turning a clinical space into a localized trauma ward to trick the body into healing itself.
Which brings us to our topic for today's deep dive. We are looking at the O shot, also known as the orgasm shot. If you haven't encountered this yet, it's a procedure where a patient's own blood is drawn from their arm, placed into a centrifuge machine, spun down to extract something called platelet-rich plasma, or PRP, and then injected directly into the clitoris and the anterior vaginal wall.
And the internet is absolutely saturated with marketing claims about
Right,
both.
totally. Claims about how this will improve arousal, increase natural lubrication, and even act as a treatment for urinary incontinence.
The claims are certainly bold, and like you said, they are everywhere.
But evaluating the marketing hype is not our mission today. Today, our mission is to look specifically under the hood at the risks and the side effects. Why should you, the listener, care about the downsides of a wellness procedure? Because navigating the world of elective, intimate medical treatments requires knowing exactly what you are signing up for, physically and biologically. Okay, let's unpack this.
Good place to start.
Before we even look at the risks, we need to understand the biological baseline. What exactly are we extracting from the arm and injecting back into the body?
Right. To really grasp the risks, you absolutely have to understand the underlying mechanism. So the core of the O shot is PRP, or platelet-rich plasma, and this is an autologous treatment.
Meaning it comes from you.
Exactly. Autologous simply means the material originates from your own body, rather than some synthetic chemical created in a lab. So when a clinician draws your blood, it looks like a uniform red liquid. But when they place those vials into a centrifuge, the machine spins them at incredibly high speeds. The heavy red blood cells sink to the bottom, while the yellowish plasma and the platelets float to the top.
I feel like most of us probably just think of platelets as the microscopic scabs that stop us from bleeding when we get a paper cut.
Yeah, and they absolutely do form clots, but their role in regenerative medicine is entirely different. Platelets contain these tiny storage units inside them called alpha granules. Think of alpha granules like biological flare guns.
Okay, flare guns.
Right. When they are injected and activated in a new tissue area, they fire off a highly concentrated cocktail of growth factors.
And what happens when those growth factors hit the surrounding tissue?
They act as signaling proteins. They basically alert the body's stem cells and macrophages to rush to that specific area and start repairing and building. They stimulate the production of new structural collagen, and they trigger a process called angiogenesis.
Which is the creation of new blood vessels, right?
Exactly. Angiogenesis is simply the formation of brand new blood vessels. In theory, more blood vessels mean an increase in steady blood flow, which is the underlying physiological goal for improving tissue health and sexual function in that specific localized area.
So you are basically injecting a highly concentrated repair signal to trick the body into an aggressive remodeling phase.
Yep.
But before we explore what happens when that signal goes wrong, we have to talk about what happens when the procedure goes flawlessly. Because even a perfectly executed procedure has an aftermath. The body still has to react to a needle puncture and a sudden influx of fluid in a highly sensitive region.
And the geography of the injection site is crucial here. The vagina and the clitoral region are incredibly vascular, meaning they are packed with blood vessels and they are extraordinarily dense with nerve endings. So because you are introducing a needle into that environment, there is a guaranteed expected physical reaction. But it's important to frame these expected effects as generally mild, localized, and transient.
So when we look at the clinical literature, what are the most common expected reactions in those first 48 hours?
Patients should expect mild soreness or tenderness at the injection sites that typically lasts anywhere from 1 to 3 days. There will almost certainly be temporary swelling and redness. Furthermore, clinicians often inject a significant volume of fluid during this process, sometimes up to 5 cc's of PRP.
Let me stop you there for a second, because 5 cc might sound like a tiny amount if you're thinking about like a glass of water, but Considering the confined tissue space of the anterior vaginal wall, that is a massive volume.
It is a profound amount of fluid to introduce rapidly into a tight space. That volume physically stretches the surrounding tissue.
Wow.
And that stretching is what accounts for a very common sensation patients report, which the literature describes as vaginal fullness or pressure. You are essentially filling a biological water balloon. Additionally, the sheer act of a needle passing through heavily vascularized tissue means minor bruising or transient spotting is completely normal.
There was one detail in the research regarding that swelling that really caught my attention.
Oh, about the urinary side effect.
Yeah. One study tracked a rare but completely non-threatening side effect where a patient experienced transient straining during urination. And the medical solution was to use intermittent self-catheterization for a few days until the issue resolved. Now, most people hear the word catheter and instantly assume some sort of catastrophic permanent damage has occurred.
I know, it sounds scary. But that reaction is a perfect example of why we have to separate our fear of medical interventions from the physiological reality of what is happening.
Right.
The urinary straining in that study was not caused by permanent nerve damage or organ failure. It was purely mechanical.
Just the fluid taking up space.
Exactly. The temporary swelling from that 5 cc of fluid physically pressed outward against the urethra, narrowing the passage. Once the acute swelling subsided over a few days, the pressure lifted and normal function returned.
It sounds incredibly similar to the soreness you experience after a really intense, heavy workout, or the aching stiffness in your deltoid muscle the day after getting a vaccine.
Yeah.
It's not a sign that you are injured or that your body is failing. It's just the dust and noise of your body's cellular construction crew arriving at the site to do their heavy lifting.
That is a wonderful way to conceptualize the biology at play. Those expected side effects, the swelling, the redness, the heat, they are the hallmarks of the body's natural inflammatory response.
Which we usually try to avoid.
Right, inflammation gets a terrible reputation in wellness circles. But acute controlled inflammation is the mandatory first stage of the healing process. If you took an anti-inflammatory drug to stop that initial swelling, the growth factors couldn't do their restorative work. The body needs that inflammation to widen the local blood vessels so the repair cells can arrive.
Okay, so that covers the expected aftermath, the necessary dust and noise. But while those mild effects fade within a few days, we have to look at the other side of the coin. What happens when the procedure leads to rare but very real complications? Let's talk about when things actually go sideways.
The primary risk, as with any procedure that breaks the skin barrier, is infection. It is statistically rare, but the consequences in that specific anatomical area are severe. Symptoms of a developing infection would include intense, localized heat, severe and spreading redness, abnormal discharge, or systemic symptoms like a sudden fever and chills.
Is an infection usually a failure on the doctor's part or something that happens after the patient goes home?
Honestly, it can absolutely be either. A practitioner failing to maintain strict, sterile aseptic techniques during the blood draw, the centrifuge process, or the injection itself can introduce pathogens.
Right.
However, the patient's post-procedure care is equally critical. The injection sites are microwounds. If a patient touches the area with unwashed hands, engages in certain activities too quickly, or applies topical products or cosmetics to the area before the skin has fully sealed, they can easily introduce external bacteria into the tissue.
Okay, so if infection is an external pathogen entering the body, we also have to consider the internal physical damage a needle can do. I mean, we are talking about the clitoris, an organ with thousands of densely packed nerve endings.
Nerve injury is a heavily documented, albeit rare, risk. And this can happen in two distinct ways.
How so?
First, an improperly placed needle could physically nick or sever a small nerve branch.
Oh.
Second, the rapid introduction of that fluid we discussed earlier can compress a nerve against surrounding pelvic structures.
Ouch.
Yeah. Both scenarios can lead to neuralgia, a condition patients often describe as a sharp, sudden, electric shock-type pain. It can also manifest as localized numbness or extreme hypersensitivity, where even the friction of normal clothing becomes deeply uncomfortable.
The sources do offer a silver lining there, noting that while nerve pain is severely distressing, it is very rarely permanent because peripheral nerves have a slow but robust capacity to heal over weeks or months. But the sources also mention the risk of scarring and significant bleeding.
Minor internal scar tissue can certainly form if the needle technique is aggressive or improper. However, we should contextualize that risk. Severe tissue necrosis, which is the actual death of the tissue due to a blocked blood supply, is highly unlikely with a liquid like PRP.
Because it's not a thick gel.
Exactly.
Yeah.
The risk of necrosis is significantly higher if a practitioner is injecting thick, synthetic hyaluronic acid fillers into the same genital area, which can accidentally plug an artery. As for bleeding, because the area is so vascular, complications can range from stubborn, unsightly bruising to a hematoma, which is a larger, painful pooling of blood trapped underneath the skin.
Okay, so here is where the research presented a complication that genuinely made me do a double take. The medical literature explicitly lists allergic reactions as a potential severe complication of the O-shot. I have to push back on that. If the procedure uses autologous material, literally your own plasma, how is it biologically possible to have an allergic reaction? You cannot reject your own cells.
What's fascinating here is that your logic regarding the blood is entirely sound. You will never mount an allergic response to your own PRP. The allergy risk stems entirely from the required auxiliary medications and the processing equipment.
Oh, I see. So the payload is safe, but the delivery system is the threat.
Exactly. To make injecting a needle into the clitoris tolerable, practitioners apply a highly potent topical numbing cream, commonly referred to in the industry as BLT cream.
Like the sandwich.
Like the sandwich, but it stands for benzocaine, lidocaine, and tetracaine. A surprising number of patients have undiagnosed severe topical allergies to those specific anesthetic compounds. Furthermore, the specialized vacuum tubes used to hold your blood while it spins in the centrifuge are not empty.
What's in them?
They are coated with chemical anticoagulants to prevent your blood from clotting during the separation process. If your immune system is hypersensitive to those specific synthetic chemicals, trace amounts injected alongside the PRP can trigger a localized allergic reaction, presenting as severe itching, rash, or intense abnormal swelling.
Wow. Knowing that the equipment and the numbing creams introduce these hidden risks is crucial. It forces us to look beyond just the needle. We have to look at how a patient's pre-existing internal biology can turn a seemingly straightforward procedure into a dangerous situation. Let's explore the biological roadblocks. Who should absolutely stay away from the O-shot?
The medical contraindications for regenerative therapy are very strict, and they're rooted in how the body prioritizes its resources. The first major category includes anyone who is pregnant, actively breastfeeding, or currently undergoing in vitro fertilization IVF treatments.
Why are those specific states a barrier?
Because during pregnancy or intensive fertility treatments, a patient's hormonal and vascular states are under massive flux. The body is redirecting its blood flow, its immune responses, and its growth factors toward reproduction or sustaining of pregnancy. Introducing an elective localized trauma to demand stem cell attention during that period is strongly contraindicated.
Right. Your body has bigger fish to fry. The next category the sources highlight revolves around active infections and compromised immunity. So if you have a current pelvic infection, an active urinary tract infection, or even an active herpes cold sore outbreak, clinicians will turn you away. Additionally, patients with active cancer or those taking prescribed immunosuppressant drugs are disqualified.
And that relates directly back to the mechanism we discussed earlier. If your immune system is artificially suppressed to protect an organ transplant or to fight an autoimmune disease, it physically cannot mount that necessary acute inflammatory response.
The whole process stalls.
Right. The platelets might fire off their signaling growth factors, but the body lacks the available cellular workforce to answer the call. The treatment simply will not work.
Which makes total sense. You can't start a construction project if all the workers are on strike.
Exactly. The final major biological roadblock involves blood and bleeding disorders. Because the entire procedure relies on the health and concentration of your platelets, pre-existing blood conditions are a hard stop.
So what does that look like in practice?
If an individual has severe chronic anemia, a diagnosed blood clotting disorder, or is managing a cardiovascular condition with prescription blood thinners, frequently called DOACs, or direct oral anticoagulants, the fundamental mechanics of the blood separation fail. Furthermore, the risk of a severe hematoma or uncontrolled bleeding during the injection skyrockets.
While prescription blood thinners are an obvious red flag, the research highlighted something much more subtle that I found fascinating. Taking a common over-the-counter NSAID, like your everyday ibuprofen or Advil, can actively ruin the treatment.
It absolutely can. NSAIDs, or non-steroidal anti-inflammatory drugs, work by inhibiting specific enzymes in the body that produce prostaglandins. Prostaglandins are the chemical messengers that tell platelets to aggregate, clump together, and release their alpha granules. By taking an NSAID, you are biochemically paralyzing your platelets.
That means if you pop an ibuprofen for a mild headache the morning of your procedure, you could literally be sabotaging the entire investment. The doctor will successfully draw your blood, spin it, and inject it, but the platelets will just sit there, chemically unable to activate.
Exactly.
This highlights how vital it is for you to be completely transparent with your medical provider. Withholding information about a simple drugstore painkiller out of convenience could render the whole agonizing process pointless.
And this deep complexity underscores why administering the O-shot requires a highly trained medical professional.
Hmm.
It is not just about the mechanical skill of wielding a syringe.
Hmm.
It requires a clinician who can comprehensively evaluate a patient's systemic health, their daily habits, and their hidden biological roadblocks to prevent adverse events.
Right.
A good practitioner also evaluates psychological risks.
Hmm.
For patients with a severe needle phobia, the high-stress anticipation of a genital injection can trigger a massive vasovagal response, leading to a sudden drop in blood pressure, severe nausea, cold sweating, or fainting right in the chair. Managing the patient's holistic state is just as important as the injection itself.
Okay, so let's assume you are the ideal candidate. You have no blood disorders, you are not pregnant, your immune system is robust, and you fully understand and accept the physical risks of infection or transient nerve pain.
Yeah.
There is one final overarching systemic risk you must navigate before deciding to move forward, and that is the regulatory landscape and the broader medical community's skepticism.
Yeah, the conversation surrounding the regulation of the O-shot is highly nuanced and honestly frequently weaponized in clinic marketing. If you browse websites offering the procedure, you will see the phrase FDA cleared plastered everywhere. It is designed to instill a sense of absolute federal safety. But we need to make a vital clinical distinction here. The FDA does not approve the O-shot procedure itself.
They don't approve the injection into the tissue.
Correct. What the FDA has cleared are the physical devices used in the room. The specific centrifuges and the specialized vacuum test tubes used to process and spin the blood are classified as Class II medical devices. The FDA clears them, verifying that these machines can safely and effectively separate red blood cells from plasma without contaminating the sample. However, taking that separated PRP and injecting it into the clitoris for aesthetic or functional enhancement, that is strictly considered an off-label clinical application.
So what does this all mean? Let's look at it through an analogy. It's like walking into a store and buying an FDA-cleared kitchen blender.
Okay, I like this.
The government regulatory bodies have rigorously tested that blender. They verified the electrical wiring is grounded, the blades won't detach at high speeds, and the motor won't spontaneously explode on your counter. The tool is certified safe to operate. But the government is certainly not endorsing the bizarre, off-label tuna fish and rock kale smoothie you decide to blend up and drink. They clear the safety of the tool. They do not approve the recipe.
If we connect this to the bigger picture, that off-label status perfectly explains the overarching hesitation of the traditional medical community. Major, highly respected medical bodies, such as the American College of Obstetricians and Gynecologists, ACOG, and the Royal College of Obstetricians and Gynecologists, have issued formal warnings to patients and providers.
Really, formal warning.
Yes. Their collective position is that there is a distinct lack of robust, long-term, randomized, double-blind scientific evidence confirming both the long-term safety and the definitive efficacy of elective aesthetic procedures like the O-shot.
So they are essentially stating that while small studies and anecdotal reports show promise, they don't have the gold standard data required to state unequivocally that this works predictably and is safe for the general population.
That is the core of their hesitation. The placebo effect in treatments related to sexual health and intimacy is notoriously powerful, which makes double-blind data incredibly important. However, as an analytical observer evaluating this landscape, we must contrast these specific risks against the alternatives.
Right.
While the O-shot lacks that massive, undeniable mountain of clinical evidence, its biological risk profile is inherently lower than other heavily marketed vaginal rejuvenation methods. For example, the FDA has been forced to issue explicit, severe warnings regarding burns, severe blistering, and chronic long-lasting pain resulting from energy-based lasers marketed for vaginal tightening.
Oh, wow.
And as we discussed earlier, using synthetic hyaluronic acid fillers carries a horrifying risk of permanent tissue death. Because the O-shot utilizes your own processed plasma, you bypass the catastrophic risks of thermal burns and synthetic blockages, even if the clinical data proving it works is still playing catch-up.
Which ultimately places the heavy burden of decision entirely on your shoulders. You have to independently weigh the lack of long-term randomized trials against the promising, biologically sound, but mostly anecdotal regenerative properties of platelet-rich plasma.
Exactly.
In a digital landscape saturated with information overload and highly targeted, aggressive clinic marketing on your social media feeds, your own critical thinking is your absolute best defense. Just because a wellness clinic uses a fancy trademark name does not mean the procedure is devoid of risk. And just because a material is technically natural does not mean your unique biology won't react adversely to the process of extracting it and putting it back in.
It requires questioning every assumption you have about medical marketing.
Let's bring this all together. We have covered a tremendous amount of ground in this deep dive. To recap the journey, the O-shot is a fascinating procedure that attempts to harness your own biology. Specifically, the alpha granules and growth factors locked inside your platelets to stimulate cellular healing and brand new vascular growth in intimate tissues. Because it relies on your own blood, it is incredibly safe from systemic rejection.
Hmm.
However, the mechanical reality of the procedure means it absolutely carries expected, albeit temporary, side effects like swelling, fullness, and soreness.
And it carries rare but highly impactful procedural risks, like stubborn infections and transient nerve pain, which usually stem from practitioner technique errors or failures in post-procedure aftercare.
It also requires you to navigate an incredibly strict set of medical contraindications. Everything from pregnancy to underlying immune issues to prescription blood thinners, down to the simple, everyday ibuprofen sitting in your medicine cabinet can derail the treatment. And finally, you have to operate within a nuanced regulatory reality. You are choosing an off-label procedure that utilizes FDA-cleared devices, but lacks overarching FDA procedural approval and faces deep skepticism from major traditional medical colleges.
Which brings up a final and I think deeply vital question for us to consider as we look at the source material. A massive portion of the marketing for these regenerative procedures preys heavily on the innate human fear of natural bodily decline.
Right, of aging.
They sell the narrative that the only way to maintain intimate tissue health is through expensive centrifuges and painful injections. But if we look at the broader research provided in the medical sources regarding women's health, there is compelling evidence that foundational, simple lifestyle choices can have a massive systemic impact on this exact biology.
Such as?
Well, for instance, massive cohort studies tracking thousands of women have demonstrated that simply consuming a diet consistently rich in oily fish and fresh legumes can naturally delay the onset of menopause and hormonal decline by up to 3 full years.
Wait, really? A 3-year delay in hormonal decline simply from eating more salmon and lentils?
Yes. The high concentrations of antioxidants and omega fatty acids actively influence the maturation and release of eggs and the stabilization of systemic hormone levels over time. This raises a highly provocative question. If shifting our baseline dietary lifestyle can alter our hormonal timeline by years, how much of our intimate tissue vitality, our natural lubrication, and our sexual health is actually within our daily autonomous control long before we ever feel the pressure to resort to spinning our blood in a centrifuge?
That is something to seriously mull over the next time you're standing in the grocery store making decisions about dinner. It turns out whether we are talking about setting a broken bone or trying to navigate the murky, complex, and heavily marketed world of intimate regenerative medicine, we always crave that clean, binary X-ray.
We really do.
We want the single magical shot that fixes everything immediately. But human biology is never that simple. It is messy, it is deeply interconnected, and it demands that we pay attention to the whole picture, not just the marketing.